DIC, disseminated intravascular coagulation or coagulopathy. Okay, we've got a 38-year-old woman who was hospitalized for a ruptured appendix. She developed sepsis and peritonitis. She's being treated in the ICU following surgery. She's intubated on a ventilator. Her NG tube is to suction. She has a central line-in catheter, open abdominal wound with bleeding noted from all sites. What's wrong? Well, if you don't say DIC, you weren't listening a second ago. Because it's DIC, disseminated intravascular coagulopathy. It's not a disease, but a complication of some underlying condition. It causes multi-system problems. It's life-threatening and carries a high mortality rate, about 80% or more. It's important that you recognize those patients at risk because it is a coagulation paradox. With DIC, blood is coagulating at the same time that clots are being dissolved. It's also called a thrombohemorrhagic disorder. It's caused by overstimulation of normal coagulation cascade, which causes excessive formation of tiny clots. The platelets and clotting factors are then used up, resulting in bleeding. So you end up with microthrombi, fingers, toes, tip of the nose, the ears, and bleeding from every puncture site that you might have, or your mouth when you brush their teeth, or in the catheter, or any drains that they may have. Patients at risk include those with shock, infection, OB complications, trauma, hypoxia, hematological crisis, excessive burns, and many others. The development of DIC is precipitated by endothelial damage, tissue damage, and direct activation of factor X. The most common cause is infection. So, these are showing your common precipitating factors associated with DIC. And you will find patients in OB that have DIC and in ICU, mainly. So the lab tests. ProTime, normal, 11 to 12.5. It'll be elevated in DIC. PTT, 23 to 35. This will be elevated in DIC. Fibrin split products evaluates fibrinolysis. Normal is 0 to 5 micrograms. It's also called fibrin degradation products. High levels of these also act as an anticoagulant and will contribute to the bleeding. These will be elevated in DIC. Platelet count, normal 150 to 400,000, will be decreased in DIC and it's called thrombocytopenia. They have an increased platelet destruction, which is thought to be an antigen-antibody reaction. They also have an increase in platelet use. Fibrinogen level, this is the amount that's available for coagulation, normally 170 to 340 milligrams. This will be decreased in DIC. And the gold standard, doing a D-dimer. D-dimer, the normal is either negative or less than 250 nanograms per milliliter. It's also called a fibrin degradation fragment. And this is made through fibrinolysis, or the breakdown of your clots. And so this is what tells you that you have bleeding due to DIC. Clinical manifestations. Needless to say, bleeding, mucous membranes, venipuncture sites, urine, GI tract. It's a rapid development of bleeding from these sites, from your surgical wounds, your ecchymotic lesions such as purpura, petechiae, and hematomas. On average, individuals bleed from 3 unrelated sites. That's how it's diagnosed. Also, you need to assess the GI, urinary, and respiratory tract for bleeding. You need to assess the entire body and all tube sites for bleeding routinely. And organ dysfunction related to thrombosis or hemorrhage. They can develop both microvascular and macrovascular thrombosis. Organ systems that are susceptible to microvascular include the cardiovascular, pulmonary, neural, renal, and hepatic systems. The nurse needs to use careful assessment of these systems to note changes. The patient can also develop microvascular occlusions of your extremities. So assess for pale, mottled skin, loss of pulses, or cyanosis. At first, the symptoms may not be evident, and there may only be the decrease in the platelet count. As thrombosis becomes more extensive, the symptoms are more pronounced. Some of your possible calls for nursing are, this is showing you pathophysiology of DIC. You've got your stimulus, going to affect your endothelium. Now, your endothelium is what lines all of your arteries, all of your blood vessels. If you laid it end to end, it covers 3 football fields. So you've got a lot of endothelial damage. That's going to release through endotoxins, tissue factor, cause that factor X activation through the intrinsic pathway, and you're going to initiate blood clots. And then you're going to use up all your platelets and have thrombocytopenia, and that's going to cause bleeding. You're going to have intravascular fibrin deposition, so you're going to have a thrombus. So tissue ischemia and hemolytic anemia. This is a flow sheet for the pathophysiology. Calls for nursing, fluid volume deficit related to all the bleeding. Impaired skin integrity because of the ischemia related to the ischemia or the bleeding. Altered tissue perfusion related to the microemboli. And that would be peripheral or central, depends on where it is. Anxiety related to the fear of unknown and death. And there are more. Don't forget your family that's going to walk in. You don't want your family members to walk in and see their significant other bleeding. So you make sure you know about it before they tell you. Nursing interventions. Closely assess those vital signs, your urinary output. Watch for signs and symptoms of shock. Keep in mind that your urinary output should be 1/2 to 1 milliliter per kilo per hour. 30 milliliters an hour was the standard. Now we're making it more specific for your patient. If they weigh 100 kilos, they should be having at least 50 milliliters an hour out. You need to closely assess the hemodynamics, since this patient may have either a Swan-In or CVP. Assess for their level of consciousness and oxygenation. Avoid medications that interfere with platelet function, such as aspirin and NSAIDs, because they're already bleeding. Avoid rectal meds and IMs because they'll bleed further, so you want to avoid that. Avoid straining, which will increase intracranial pressure and could cause a bleed, and you don't really want them to have a stroke. Use low pressure with your suctioning because that will cause more trauma to the tissues and more bleeding. Use very gentle oral hygiene. Avoid mouthwashes with alcohol or lemon glycerin swabs because they dry out the mouth and they increase the risk for bleeding. Closely monitor all sources of bleeding to make sure you have an adequate assessment. Make sure you give good skin care to prevent any further infection or bleeding. Administer blood products as ordered. Usually cryoprecipitate can be given to replace the fibrinogen in factor 5 and 7. Fresh frozen plasma is administered to replace other coagulation factors. Be familiar with how to administer these. Fresh frozen plasma needs to be thawed and usually takes about an hour to thaw. Closely assess their labs. Administer heparin if it's ordered. Now, heparin is controversial, but it is thought to inhibit formation of microemboli and allow for perfusion of the organs. When it started, it may make the bleeding a little bit worse until the thrombotic process is interrupted. Keep a close eye on the labs that are ordered and notify the physician as needed. And give the emotional support to both the family and the client because there is a high mortality rate and they're bleeding. And red blood is something most people like to see in their veins and arteries and not on the skin or the sheets. So you want to make sure that it doesn't cause problems to them. And that finishes this lecture.